Dr. Ellen Vora, I am so thrilled to talk to you and to have this conversation. I just have a feeling you and I are just going to talk nonstop because we have the same heart, the same vision, the same kind of thinking when it comes to mental health. And I'm just thrilled to interview you. So thank you so much.
Thanks for having me here. It's nice to be with a kindred spirit.
Oh, it is. It is. It's so good. It's so wonderful. Thank you so much. Well, people have heard your incredible bio. You have such an impressive bio. I mean, an English major from Yale, and then your medical background, and then your move over to the way you've challenged the norm in the biomedical model and the neuroreductionist approach of psychiatry to really look at whole people and the holistic approach. It's just beautiful. It's like what I've been trying to do for 38 years with my research. So that's why I'm so excited to hear you talk about what you do in such an incredible way. So before we start, can you just tell us a little bit about yourself that's not in your bio? A little bit about you, what motivates you, how you got where you are today.
Great. Yeah. I think probably what unifies what's not in my bio, but is really relevant, is that I'm in this struggle like everyone. I think that's the only reason I can really do good work with my patients, is that I have come up against a lot of the same obstacles and barriers and challenges that the people I'm helping are coming up against. And I think about the fact that, like, I teach a lot on insomnia. I am a sleep procrastinator, like beyond most people. And I am basically...
Let's talk about that.
Yeah, I'm a night owl, right? Like, to me, I love social connection. And why is it that the conversation never really gets good until midnight?
Exactly.
And I preach, go to bed at 10, but I do until something pulls me in the other direction, which to me is perfect. It's sort of the advanced college seminar approach to how do we balance doing the right thing for our body and our overall well-being, with the fact that the goal is not just perfection. The goal is a fulfilling life, and sometimes the right trade-off. Yeah.
That is brilliant. And I don't mean to interrupt you there, but what you've just said there has just set so many people free, because I write lots of books, as I've told, as you know, and I work through the night because I have no disturbances, and then I'll sleep in the morning. And I know that's not the ideal pattern, but it works for me. And I'm so glad how you've said that sometimes you've got your ideal, but there are times in your life where fulfillment will override. So it changes your pattern, that great conversation that goes on all night, which changes it compensates for that, what may have happened biologically because you didn't sleep, but that there's another benefit. There's a trade-off that's actually really good. So I'm so glad you raised that point.
Yeah, we could talk about that alone quite extensively. It comes up all the time in life. The real work is discernment. It's making the moment-to-moment choices of what's the act of self-love right now. Is it the 10 p.m. bedtime? Is it the 4 a.m. bedtime?
So good. That is so good. Yes, let's definitely dive into that. If not in this conversation, in another. Hopefully this one will start it.
And I'm a parent. I have a 4.5-year-old daughter. And so if nothing like in life kicks you in the face quite like being a parent, I don't know, so I think that
I've got 4 kids. Yeah.
Yeah, I can't imagine. 18 books and 4 kids. God bless. It's hard and it's survival. And I think that people like me come into parenting very precious. I was sort of like, how do people wind up so messy with it? Why are the kids eating French fries off the floor of the minivan? I'm just going to have my beautiful baby in the carrier. We're going to walk down the street and it's just going to be blissful and everything will be organic. It's like, and now I just want to punch my earlier self in the face. It's like, and I think that, the reality is that, parenting, which is like the greatest drug, it's this transcendent experience. It makes everything in life less convenient, but deeper and more transcendent. It's really humbling and so equalizing, and just lets you realize there's just spiritual growth in like all the micro moments with kids, that you realize all of your shadow, all of your blockages. It just helps hold up this mega mirror on where you still need to grow. And then I think with health, I struggle. Like with health at this point, I'm fairly in balance, but that's after about a 10-year, very inefficient process of learning, how do I get my body in balance? And this was all part of the crisis that I was in throughout medical school, and a part of residency was, I don't really think I'm helping my patients thrive. Like I could tell I was helping patch them up in a certain way. People would get on a very elaborate cocktail of psychiatric medications. They'd be patched up to an extent. They wouldn't be as quote unquote symptomatic as they were coming in. But like there was still this gut check of, are they thriving in their life? Like, am I proud of this work? And oftentimes I would actually come to the awareness that, you're always on that delicate balance around do no harm. And I would sometimes really think it was a judgment call whether I truly was doing no harm. And so for me, it was such a crisis. And I couldn't get my body healthy, couldn't get myself feeling well, didn't really think I was getting my patients feeling well. And I went on a long autodidactic journey of how, looking at other modalities, Eastern modalities, how different disciplines around the world think about health and healing, to find an approach that actually made sense to me, that actually moved the needle for my patients and for my own struggles.
That's incredible. And it really has been a journey. You started off as an English major and then transitioned. Can you tell us just a little bit about that? Because it's such a great story that, how you've got to where you are today, and so highly credentialed and so much that you've studied, but you've almost gone full circle, haven't you? Back to ancient medicine.
That's true. Yeah. I think I'm a weird combination. I think to make it through medical school, it's helpful to be someone who, it's very hardworking and sort of in a Chinese medicine sense, like somewhat metallic, kind of like just like sort of you get on a track. It starts freshman year of college when you take general chemistry, and then you just keep checking these boxes, and it's a never ending path. You take orgo and you take physics and you take math and biology and all these labs, and then you take the MCAT, and then you apply to medical school, and so on and so forth. Yeah. And I am someone who you can put me on a path and I will keep going with inertia. But I'm also pretty radical and sort of kind of a weirdo and a questioner and marching to the beat of my own drum. I think those two things don't go hand in hand all that often, that you're like, I will jump through every hoop you give me and march to the beat of my own drum.
No, I can relate to that. I can relate to that. Yeah.
And that's why we're kindred spirits.
Yeah, and so, for sure.
And so I always felt like I'm different here. And I guess in a way, you could have saved me a lot of trouble in med school as I was trying to pick my specialty. And I was so tormented by that decision. And I was or tortured by the decision. I was thinking, all these different specialties I was considering. And they could have just told me, if you were an English major in college, you're going to be a psychiatrist. So stop going around in circles about this. Yeah. Like in college, you get to this height of what I'm really passionate about are the complexities, the gray areas, the nuances of what it is to be human on this rock barreling through space with no certainty. And we're sort of here to try to feel fulfilled or connected to purpose or to experience love or whatever it is, or to show up in service or shift the whole enterprise from fear to love. And I think that I was really thick in that by the end of college. And then med school is this sort of careening to the bottom of a pit where you're back to learning the cut and dry sciences, which are cool. Like science at its most extreme is totally magic.
It is.
It's very spiritual.
Very. I always say science and spirituality are the same thing.
They are at the extreme.
Yeah.
But learning nephrology in med school is not spirituality. So I was like
the tools of the trade kind of thing. The basic mechanics.
And so I think that I felt pretty disenchanted. I was like, this is not engaging me. I don't feel as lit up or turned on by this material. So I found psychiatry as the place where it's okay, at least here we're exploring the depths. We're groping in the dark of the human condition. And that's where I like to be. But then in residency, in my psychiatry residency, it kind of took the mental health, our human condition, and turned it into a cut and dry science. These symptoms equals this diagnosis equals this medication.
And as you said, you spent how many years doing that? You didn't, instead of learning about the variability of humanity, which you'd learned more as an English major, here you learned to diagnose and attach a label and attach a medication.
Yeah.
And kind of missing the person.
Completely missing the person. I remember there was a moment in I think I was in my third year of med school. I was in my surgery rotation, and we're standing around in the OR. We're doing an appendectomy. So someone came in with appendicitis. We're removing the appendix, and you're kind of just talking while you're doing the surgery. There's a radio playing in the background. And I'm making small talk, but I'm also trying to get something out of this experience. And I turn to the surgeon and I'm like, so why do people get appendicitis?
Yeah.
To me, that felt like the obvious question. I thought I was asking too stupid of a question. Yeah. And he was like, we don't ask why. It's we cut. We don't ask why. And
we cut. We don't ask why. That's very shocking.
And I'm like, all I do is ask why. From the minute I wake up in the morning to throughout my dreams at night, it's all why. Right? It's making sense of this. It's learning, it's growing from what's coming down the pipeline at us from our experiences. And with health, especially, you look around, we're in so many, we could list the different epidemics we're in. We're in an anxiety epidemic and insomnia and a loneliness and, we're many others.
On
and
top of the obvious,
a pandemic. Yeah. And it's like, I feel like why is our path forward? It's like, how do we move out of this? Why did it come to be? What can we do differently going forward? And so to me, like actual progress is all about why. Is understanding the roots and the underpinnings of why things are out of balance.
Oh, that's incredible. For 38 years, I've done cognitive neuroscientific work around the human condition and worked in Africa that's where I grew up, and worked with all across everything from learning disabilities, dementias, traumatic, and just trying to understand the science of thought and how minds work and the depth of the human condition. And I even went after my initial phase of research, I did this, okay, I'm not going to do lab work. I'm going to actually work with humans and actually try and understand what this thing means, and then came back and did more formal clinical trials and whatever. But the whole thing was, as you say, to try and understand and ask the question, why do people do what they do? And the big conclusion at the end of the day is you just never stop asking those questions. So everything I've developed has been based around become aware, self-regulate, and find out why, and then reconceptualize, embrace, process, and reconceptualize. And I say all that to say that I didn't mean to go on about that. I just wanted to say that I hear what you're saying. I hear that we've got to keep asking those questions. Otherwise, we will become dry and clinical and forget all about the human and the human experience. And, if you're dealing with psychiatry, you're dealing with a human. Every medicine, if you did appendectomy, you're still dealing with a human. What did happen to cause that, So.
In the context of their whole life, and I think about that. I mean, certainly with mental health, to me, it's an obvious approach is to take a holistic approach, to think it's not just what is your genetic chemical imbalance and what pill corrects that. To me, even if that is, on some level getting at some truth of mental health, and I continue to sort of question that, but even still, it's not pertinent. What are their sleep habits? What is somebody eating? How's their digestion? How are their relationships? What is their job like? Are they disenfranchised in their life? Are they marginalized? Do they feel like they have a locus of control or autonomy in their work? Do they have a connection to purpose and meaning? So these things are determinants of our mental health, but they've been a bit, they're
just pushed to the side. They're not even considered. I mean, you look at those traditional psych evaluations. I mean, there's just a little list of symptoms, but there's absolutely nothing to do with the whole person's narrative. And that's what the clinical trials I do. We look at the person's narrative. It's the most important thing. You've got look at what's going on in our country at the moment with racism. I mean, this is a toxic issue that is affecting the perpetrator and the perpetrated. We've got to look at the whole story.
If you're treating a Black, Indigenous person of color in your practice and you're evaluating the chemical imbalance in their brain, like
you've missed it.
99.9% of why somebody is showing up in your office and saying things are hard right now. So yeah, and there's something about psychiatry, which I also really love, which is that it's extremely humbling because you never get it. You never arrive.
Oh, I love
like,
this.
You're just, every time I feel like I reach like this false peak of like, okay, I have a couple really good patient journeys that I've been, witness to. And it's like, okay, I understand how to approach this problem. And like, I kind of know how to walk with someone down that path. And then the minute I ever arrive at a place, it's like, I get it. And it's like, you'll meet someone and it just throws it all upside down, which is great. I love to be thrown upside down in these ways and to just realize there's just no dogma that holds water under all circumstances. Human mental health is infinitely complex, and you kind of have to show up as a total beginner to every patient.
What you've just said now is so powerful. Just say that again. I mean, that is just so powerful. You've got to literally say that.
We have to show up as a beginner with every patient. And I think it's applicable if someone's listening and they're not, a mental health practitioner, it still applies in our lives, right? Like when we have a conversation with a friend, to show up as a beginner, when we're approaching the conversations that we're having right now around racism and racial injustice, to show up as a beginner. We all, I think, like really are uncomfortable being so flawed and bad at things we feel like we should have already known. I certainly have done my fair share of being sort of working this out in practice, where I'm sitting across from a patient and I feel like when I don't know what's out of balance in someone, when I don't know how to approach it, you can feel really like it's very triggering to be like, shoot, like I can't admit that I don't know. I can't, like they should have been seeing an older, better, smarter psychiatrist, someone more inside the box, and then you kind of wade through all the ego and all the triggers and you get back to a place of like being in alignment with intention, which is like, well, I am giving this person my meticulous attention. I'm showing up with integrity. And I think like that's probably worth more than any amount of I've got it all figured out. And I think this is true in our conversations these days. It's like showing up with generous, deep listening and observation and a kind of comfort with the fact that I don't know.
I love that. That's beautiful, because that it goes to the basic core of how one can build a relationship. And as you know from research, the most important element of helping someone, whether you're a psychiatrist or psychologist or whatever you are, is the relationship. It's not the actual techniques, it's the actual relationship that is built and how that makes the person feel. So I love that. And taking that attitude of it's just start as though you don't know anything, start at the beginning as though you're a beginner, because that person's an individual case study. That's so good.
Being said, I think the technique, I do find that more and more I'm also practicing witchcraft at the same time as sort of listening and observing and bringing a beginner's mind to my patients. It's sort of become more and more, I almost do it involuntarily, like that it's almost like a Reiki or an energy work I'm doing at the same time. You're sort of talking here and energetically impacting here. And I had a session yesterday, and he was very constipated for about 3 days. And we talked about everything coming up, and he had a big emotional purge in the conversation. So, who knows what the real cause was, but I was also sort of like energetically just sort of like focusing on his bowels, and just like doing that work. And of course I got the email like 10 minutes after the call. You'd never believe what just happened. So,
don't bring me the evidence, please. I'll believe you. The email's good enough. Yeah. Oh, that's amazing. But you talk about the energy, and that's part of my work has been, I developed a theory years ago on the mind, because I felt that's an area that just like so misunderstood. And I've been trying to understand that for 30 years. That's what a lot of people, scientists do, is, you start your research and you spend the rest of your life trying to understand it, and basically trying to understand the mind, the unconscious mind, the subconscious and the unconscious, because there's so much confusion around that. And one of the things, just to talk about the energy, is that what I do understand now after 38 years, well, I'm starting to understand, I should say, is that our unconscious mind is the biggest part of us, and quantum physics is a great way of understanding mind, and energy is what we are at our most basic level, and it translates into the physical cells and what we see. So that energy, when we are toxic or not dealing with stuff, or like this guy had a big issue coming up, and our unconscious mind knows truth. It's very wise. Our unconscious mind is connected to wisdom. It's immersed in wisdom. The scientists have shown the gravitational fields that in quantum physics, and they can be measured, and they have the values of love, which is so interesting and at our core. So if you've got toxicity, I'm just relating to this because my audience have heard me teach this stuff so often, so I'm relating to what you've just said to help them understand the context of what you're saying, so that that energy can get blocked if you're toxic. And it literally does block on an unconscious level, and your mind-brain connection exists. So your mind and brain are separate but inseparable. So that is going to then reflect in your body. Your body will manifest. I've just done a clinical trial showing that once yet again, that you're going to have whatever goes in your mind is going to affect your body, and your unconscious and your brain are going to be reflecting that very quickly. Your conscious mind's a little bit slower to actually kind of wake up, but your body will express that. So when you talk about we impact each other, people, when you're praying for someone, when you're laying on hands, whether you're sending good intentions, it's all the same thing. You are helping people to respond to that wisdom and release that energy, and it's a prompt from your subconscious mind into your conscious mind, and we need to listen. So you are helping him do that. So there's my little 5 cents worth of neuroscience, mind body science to orientate what you said.
It makes me tear up. I feel so seen in sort of my beliefs with what you just said. And I think about this, especially as it pertains to autoimmune disease. I think a lot about autoimmunity, another one of our current epidemics. Yeah. And I've always thought that it's almost like we have a little bit of an either or mindset. Like, is this starting from is this a physical, material, chemical issue? Like, is Roundup in our food causing dysbiosis or an imbalance in our gut flora and causing intestinal permeability or leaky gut, which is allowing certain particles of food to get into the bloodstream and provoke the immune system, and through molecular mimicry, it's attacking our own joints, whatever it is.
Yes.
Or is this a psychospiritual phenomenon? And I think actually what's really true is it's always both. And I'm not even sure there is a chicken or the egg, or that it even matters. It's sort of like there's divine timing to how these things converge in our lives.
Love that.
And I think about with autoimmunity, I think culturally right now we have a lot of conditioning that gets in the way of us experiencing a state of self-love. We've mixed up like what self-love is, that it can have a component of humility. Like we sort of think it's arrogance or being conceited, and like actually like a sort of place of recognizing your own, whether it's divinity or just like that you're just a flawed human trying to do your best like anybody else, and that's enough. like to be able to be in a state of self-love and celebrating yourself while being humble. Like that's not our cultural memo. We don't get that memo to be in that state of mind. And I think that relates on some deep psychospiritual level to the fact that our immune systems attack our own tissue. Like we kind of have, in the very deepest sense, like an attack on ourselves. And I think that it's an entry point, for how we heal.
I absolutely totally concur with what you're saying. And it's just the most recent trials that I've done show that I teach about mind management. That's kind of what I've brought it into, to how mind, brain, the science of thought. And just seeing people in our control group who didn't get any mind management, but became aware of all these issues like you've been describing, but didn't have a way of managing their mind, how they got so bad. I mean, down to even their telomeres in 9 weeks shortening significantly, which is quite something. And obviously the cortisol, we saw significant changes in homocysteine, everything that has been predicted, we confirmed. But in the experimental group, you give someone mind management and you tell them it's okay, anxieties, we all experience it. It's a normal thing. Yes, there'll be cases in times where it gets out of hand and it can become toxic, but you can learn to manage it. And just giving them the tools of managing that mind changes the energy in the unconscious mind, teaches them how to tune in, and teaches them how to start becoming aware of how they can deal with all the things going on in their life. That autonomy that leads to that awareness, that leads to that dealing with those toxic thoughts and reducing the toxic stress, and just the changes in well-being. It's unreal. It's like a literal path to empowerment that we saw. Changing in their physiology, their brain physiology, neurophysiology, their life. And didn't mean it was all great and perfect. I always talk about freaking out in the love zone. You're still going to cry and have issues, but somehow there's a level of autonomy that's come in, and there's a level of being able to reduce that energy knot. You talk about an energy, you talk about someone who impacted you, I didn't get the name of some spiritual healer who said to you that anxiety is unprocessed sound, and you went on to unpack that. So he explained it to you, and you kind of worded that as suppressed. We don't deal with our issues, we suppress them. And that's a lot of what my work has been, and my recent clinical trials show that when you suppress your thoughts, it changes how your brain, we can see it in a QEEG, you can see it in your behaviors. There's evidence of suppression. And if you don't, you have to embrace it and process it and go through the pain, etc., etc. And you were saying that kind of stuff. So I was all excited, and I thought, gee, we got to talk about this. We mustn't stuff our stuff down. Do you recall?
It's funny. I can't remember which energy healer this was, but I certainly recall this. And to me, it's just part of my overall understanding of what makes us up. Like it is energetic and it is vibration. And like in mental health, we have this saying, what we resist persists. And it's like when something,
so good. Mm-hmm.
When we're feeling, when an emotion wells up, like we have this sort of cultural, like we're emotion phobic. If we're at work and we start to cry, we say, I'm sorry.
Yeah.
If we start to cry at any point in our life, we like suck it back and we do the weird breathing thing, like, and it's like, we're never letting it flow. Like we just need to let it all flow. Exactly. And it's sort of, there's a paradox here. Like everyone thinks that if they can just like push the feeling down or under a carpet, that it goes away. But no emotion has ever been successfully pushed under a carpet. No trauma or experience. Like it stays in there in a very energetically real way.
Exactly.
And it impacts our well-being. It impacts in sort of a Chinese medicine perspective, like the flow of qi or the flow of energy around the body and beyond. And so I think that like with my patients, one is I just I give people permission to let it be big. Even in a psychiatrist's office, I'll see patients like say sorry for crying. It's like you're saying sorry to your psychiatrist for crying. Like you're in surround sound tissue boxes. Like I have this effect on people. This is what this is about. Let this flow. Let it be big. And to give people sort of like a new understanding of like, oh yeah, maybe I can let this be big and really have a good cry and let it flow. And I want my patients to do whatever practice excavates energy well for them. And that looks different for everyone. For me, I love to do a particular shaking exercise. I learned it when I studied integrative medicine at the University of Arizona, and they put on this shamanic drum music and you just shake. And you could do this for 2 minutes and you experience a shift. Yeah. And you feel like, what's really sacred is when like deep buried unconscious thoughts bubble up, something that was sort of, I think of it as like it was lodged in my hip or something.
Yeah,
it's like it comes up and then I can look at it. And it's usually like a very core personal exquisite emotion. You know, it's not like something you can point to. It's not necessarily a memory. It's an emotion that was within me. And now I have practices for letting these things flow, and you feel lighter afterward. You feel more capable of taking in the new feelings. I think we have an expanded capacity to feel deeply and to feel empathy when we have a really good system for metabolizing our feelings and moving through it. And so, yeah, I just want people to lean into what they're feeling and to have some practice of shaking or dancing or journaling or painting, where it's like you let what's in you, you make it manifest out in the world. You move that energy.
Oh, I love that, because energy cannot be lost. It can only be transferred. We all know that's a basic principle. So and I always tell people that I always teach on thoughts, and a thought has got emotions. And I always use these images. I don't know if you've ever seen my images of the toxic tree for a toxic thought. And then I use let me grab this healthy tree for a healthy thought. Because thought, the memories are built in the dendrites and the neurons, and they look like trees. But, just for people to recognize that a thought is such an enormous thing, and it's inside of it, it's got all this information, which are memories, and the memories have got emotions. So a thought is this massive, huge tree that just never stops growing, and it's got all the information and emotions. And when people can start recognizing that, that's going to take years to embrace and process and reconceptualize, so it's just basically saying what you're saying, just in a different way. And it's so important to get it out and to be able to transfer that energy, because if you suppress that thought, it will explode volcanic mode, as you said. So the shaking or crying or the screaming or the tapping or the breathing, they're such great basic fundamental energy releasing, and then you can do more intellectual work on the process. I love that. I love what you're saying. You also said, like, resistance is a dance against our feelings. You made that comment. I listened to one of your you see, you make all these great comments that
I think I'm always in like a trance state when I'm on a podcast.
It was just so great though. But resistance is a dance against our feelings, and that's so true. You're resisting what you've got there. You're kind of trying to push away from it and avoid it.
It just, like, to use like a Freudian term, like, things proliferate in the dark. Like when we resist and push things back, right? Like they redouble their efforts. And I treat anxiety quite a bit these days. Anxiety falls into this parameter, this framework perfectly, where when we feel anxiety coming on, the idea of strong arming it or white knuckling it, anxiety doesn't play that way. It really just, it sees that and it says, no, I will make my voice heard, and so it's like only when we actually surrender and say, like, okay, let me feel this, that's when it can actually sort of, the wave can crest and resolve. And I think about this a lot in my practice. The way I talk about it with patients is that it's like we have false anxiety and true anxiety. And false anxiety is a big focus in my practice. It's the sort of, and it's not to invalidate any, like to say like your anxiety isn't real. That's not the idea of it. It's probably could stand to be reframed, but it's basically using Julia Ross's, this is her thinking around false moods. This comes from her book, The Mood Cure. And it's basically that there are physiologic, mundane events that trip our body into a stress response. And that stress response can feel synonymous with anxiety, can feel like a panic attack, but it was actually just a blood sugar crash. It was actually just that we're sleep deprived, or we're over caffeinated, or we're under caffeinated, or we're in interdose withdrawal between our Lexapro doses. These different things that can put our physiology out of balance. And then we label that as mental illness. And so in my practice, that's the low-hanging fruit. We start with all the ways that someone might be getting tripped into a false mood, into a false state of a stress response that's manifesting as anxiety. But then what remains after that is what I think of as true anxiety. And that's not something to pathologize. That's not something that we should attempt to medicate away. You couldn't breathing exercise or blood sugar that away if you tried. It's basically something to honor and listen to and embrace. And it's here to convey information to us. I think we're uniquely in a moment in time right now where we're starting to understand that when there's like an awakening force pushing, that we should actually let down the guard and listen. Because like our anxiety, when we have true anxiety, that sense in our gut, that inner knowing of like something's not quite right here. It can be about our own personal lives, is something out of alignment in the work we're doing or in a relationship or, whatever it may be. Or are you actually here as more of an activist? Like, are you the one who's sort of a prophet attuned to something out of balance more globally? Whether your mission is racial injustice or climate change or mental health being a broken system, whatever it is, or combination of everything important right now. And to basically that anxiety is conveying a message. And when we actually let it get its message across, that anxiety is sort of like, I'm satisfied now. Thank you. I will see myself out of the room. And what you see is someone now just channeling that energy purposefully, but they're not saying, I feel anxious anymore. They're not identifying with that sort of, it doesn't feel like a pathology or like a symptom anymore.
That is so beautifully said, and so counter to the current paradigm or narrative of you symptom, you have an anxiety disorder, which is like a pronouncement of giving someone cancer or something, which is what people have got in their minds. And I'm so glad you've explained it so eloquently and beautifully, because that's also what I've been teaching for years, and the process I developed is to help people to listen to those as warning signals and to even celebrate them. It's so wonderful to hear a doctor, a psychiatrist who has got all this experience, who's so educated, saying that same thing. This is a message that we need to get to the world, that anxiety is not a disease. We don't have to, as Joanna Moncrief, I'm sure you know who Joanna Moncrief is, said we're medicalizing misery, we're pathologizing pain. You don't need to pathologize. That's not how to treat it. The way to do it is to embrace it and process it and reconceptualize it. And, that's just, you've just explained that so beautifully. And that's totally what I teach, and totally what my most current clinical trials show, that when you do that, when you do exactly what you've just described, you reduce anxiety by 81%. I mean, that's massive, and it's never going to go away. I always tell when I was practicing, but I tell everyone that I now talk to, it doesn't go away, but you learn to manage it. So it will reduce, so the toxic effect of anxiety will reduce by up to 81% just through mind management, which is awareness and reflection and the why and the processing, all that stuff. And we all can do that. And I love how you've stressed that we've got to look at the physiological as well as what could be a toxic trauma or a toxic habit. So there's the two elements. So once you've eliminated the physiology, we mustn't forget that, then to deal with the other component that could just be what's going on in your life. As you say, the collective global COVID-19 making us think again. People have forgotten how to think, and they're seeing a lot of things about themselves that are making them anxious, which they haven't even thought about for years. So it's suppressed stuff coming up, or the racism issue, which is years and years of being suppressed. It's now in our faces. We've got to get uncomfortable, and we've got to deal with it. We can't push it back down. It'll go back more toxic. We have to process through it. We can't do this dance, as to quote you. We can't do this emotional dance. We have to deal with our stuff.
I love about this is that it actually does bring more hope than our current psychiatric orthodoxy, like where we're at right now. And these are all stepping stones. Like our current orthodoxy is to basically, it's the disease model. It's basically saying, this mental illness of yours is not a moral infirmity. Good. Glad that that's been canceled. Yes. But now we say it's a genetic chemical imbalance. It's corrected with a pill. And that's great. We've sort of worked to lower the stigma around mental health. We've given some people sort of an amount of hope that there's a fix for this. Mm-hmm. And then now we are ready to shift into the next paradigm with this, because at this point there are there are millions of people who have found for one reason or another, this model didn't meet their needs. Mm. So, and this is where the nuance and the thoughtfulness around how I address medications, this is so important.
Yes, let's talk about that, because you're an absolute expert when it comes to explaining this.
In my book, I sort of open this paragraph with strap on your seatbelt and be patient. This is nuanced, because there's so much that is sensitive and really charged around this. I'll say, as the caveat initially, is that I'm actually not dogmatically against psychiatric medications. And I'm grateful to the people, the sort of other holistic psychiatrists who have been very courageous and going forward and saying that they want to stop prescribing psychiatric medications for everyone. And that's given me bravery to kind of say, hey, that's what I'm sort of starting to sense in my own practice. However, as we talked about before, I've been doing this long enough to know that any dogma I hold tightly to, I get kicked in the face. And it's I've had patients who have been so helped by their psych meds. So to me, it's if that's what's working for you, hallelujah. That's not something to question. This conversation that we're about to have is not a reason for somebody in that position to second guess themselves or to doubt it or to think it's somehow a morally superior thing to do to get off of meds. That's not what I mean at all. I think if you've found something that works for you, consider yourself a lucky one, go forth, take your meds. And then if you are sort of the millions of people who haven't been addressed in this conversation, whose needs haven't been met, whether it's that you're not helped by meds, or you were initially helped by meds, but the effect faded over time, or you feel like you've fully been chewed up and spit out by the mental health world, and you've kind of cycled through every med and every dosage and every combination, and you're losing hope, you're feeling demoralized. Or maybe you're helped by meds, but you experience side effects. It's sort of for all of these people where it's like, we're not giving them hope because we're not having a conversation about all the other things people can do to feel better. And it turns out there are 1,000 other things we can do to feel better. And not only are there other options and other avenues to explore, but I've come to even realize that, like, as you said, like, anxiety is not the disease. It's like anxiety, depression, ADHD. These are not the answer. They are a symptom. They're telling us something is out of balance here. And it can be physical, it can be mental, it can be psychospiritual. Yeah. And so it can be all of these things. But basically, I feel like my job often when someone comes into my office and says, here's how I'm suffering, is to look under the hood and think like, well, where is the imbalance? Where is one of many possible imbalances? And sometimes it's not a genetic chemical imbalance at all. Sometimes it's a thyroid condition. Sometimes it's hormone imbalance or a micronutrient deficiency, like someone could be deficient in vitamin B12 or vitamin D or magnesium. These are really common. Or someone is inflamed in their digestive tract. And so it can be all of these different actual root causes of how they're feeling. And if I were to start them on meds, like sight unseen, and just say, this meets criteria for clinical depression, let's start them on an SSRI antidepressant, I'm actually missing the point. I'm missing the true underlying cause in their case. And so to me, it's a hasty and sometimes inaccurate or specious kind of approach, and it misses the true imbalance at the root of their mental health issues. And so I'm always going to like ask why and say like, why is this person feeling depressed? And it might be serotonergic. That's sort of its own whole big can of worms. Like what's causing the imbalance in the serotonergic transmission, but it's investigative work. You're getting to the bottom of it so that you can address it in a targeted way at exactly the place of imbalance.
I love that approach. And I think what is interesting though, just I want to ask you a question in terms of the medications is what about people are so informed now. I've watched this shift over 30 years. I've watched the shift from people working in a much more psycho-spiritual and holistic way, sort of in my own practice over 25 years, to wanting more and more meds. I don't prescribe obviously, but I would be getting people off meds to get their mind management going, but then swung back to a huge emphasis for the last 30 years on meds. And the studies are showing that it hasn't actually improved mental health. It's worse. There's the side effects, the chemical imbalance is a myth. It hasn't ever been proven, the neurobiological correlates. This is a huge area of very solid science showing that this is not actually a very good way of treating people and that patients are not getting told this. So when they're told, and I know you wouldn't do that, but that people are getting put on these drugs, but without being told the side effects, that they can actually make an informed choice. So they get on them and then there's all these side effects and then they try and withdraw. And you speak about this as well with the withdrawal. It's not a disease coming back because there was never a disease in the first place. It is the process of withdrawal that is affecting your body. And what about telling patients about that isn't happening, about the fact that the placebo trials were more effective and that there's a lot of bias, and that's not been spoken about, but people are finding that out. Exactly. So you say the DSM is a protocol for selling pharmaceuticals. I'm quoting you there. So I've thrown a lot at you, and if you can unpack that, because this is an area of, as you know, massive controversy. People can get incredibly upset about the medications, and if, as you say, if it's helping them, because sometimes people are in such a bad place that they personally, my people that watch me know, my stand is, because I've done so much scientific research around this, I am really wary of the drugs because of the side effects and would rather go for the alternatives and holistic approach. But there are some people that are in a place where they're totally psychotic and broken from such terrible trauma that they need a 48-hour help just to get through. But this long-term concept of you've got to be on this the rest of your life, there is a chemical imbalance theory, this is a lie to people. So how do we navigate that? I've thrown so much at you.
I should have been taking notes. There's like 10 million things I want to say in response.
Okay, good.
Guarantee you I will
and
forget
I'll keep
several.
Quiet. No, that's fine. It's a big conversation, but I think it's one that needs to be had. And then if we could follow that by withdrawal, because that's a question I get so much of. So you unpack this however you want.
So, and to me, it's so important to caveat this, that there are people right now who are helped by their meds.
Yes.
And what we're about to talk about is just like we have the placebo effect, we also have the nocebo effect. And
exactly.
So this conversation sort of risks making you doubt the benefit you've had. So it's almost like I want to be like earmuffs. Like if you're helped by your meds, like we don't need to mess that up. I think that to me, yes, in large meta-analyses, SSRI antidepressants don't separate from placebo in mild to moderate depression. they do for severe depression. These meds, like placebo, is nothing to sneeze at. It's like it's an effect.
It's very real. Yeah.
I would be fine with these meds if they were a benign placebo. If this was truly just a million person sort of placebo experiment, but they're not benign. There are side effects, and to me, even more damning is the difficulties people go through when getting off of the meds. Now, if you are helped by them, it's also important to say it's not that you've been fooled. Like, they don't do nothing; they do something. Do they genuinely correct the underlying imbalance? I don't know. But I think that what they do is, to me, they sort of narrow the range of affect. So if you're very symptomatic and just, crying uncontrollably and frequently, and it's really getting in the way of your life, I think a med can narrow that. So like the lows are a little bit less low, the highs are a little bit less high, and life is a little bit more narrow. And in certain situations, you could call that an improvement. And you could see how this is maybe a bridge to you starting to get into a place where you can make the diet and lifestyle changes, where you can do the work and therapy, where you can change your mindset. Like, if that can get you into the chair and get you into that action seat, then okay, you can make a case for that. I think that what we also see is that, and I love Robert Whitaker's.
Oh, he's just the best. He's brilliant. Yeah, the Mad in America, it's one of our main referrals that I give people as well on the site as links is his work, and his book. Anatomy of an Epidemic is someone everyone should read.
Everyone should read Anatomy of an Epidemic. And to me, like, it's you should read it, and there's so much to it. But a quick takeaway that's really important is that we are more medicated than ever. You would think that we'd be better, but we're actually more disabled by mental illness. Our mental illnesses have more chronicity rather than less, with us being so medicated. And this is something I feel like I witnessed firsthand in my practice, is that if you give me a patient who's not on meds, like, to me, that's just delightful. Like, we can work a few sessions, get them shifting their diet and lifestyle, shifting their mindset, and they are flying out of the nest, no problem. If you give me somebody on meds, it's a harder journey. And it's not a journey I shy away from, but it is a harder journey. And I find that there is something in how they sort of like take something that was going to be self-limiting, like a state of crisis in life, and they sort of make it chronic. And so this feeds directly into withdrawal. So there's a silent epidemic right now of people who decide for one reason or another to get off of their psychiatric medications. And we don't need to sort of get into the why. Like, some people do it for side effects. Some people do it because they don't want to be on meds. Some people are family planning. Some people are dealing with interactions with other meds, what have you. Some people just don't fill their refills, like they're, whatever chaos happens, it's a struggle, right? To be in mental health care, and that's not always working for somebody. So basically someone's getting off of meds, and we, first of all, do not have any system in place for how to support people with this process. We're not taught it. We're not taught it. Our education is in large part kind of marionetted by the pharmaceutical industry. And of course, they're not going to teach us how to get people off of meds. Like, Starbucks isn't going to train its employees how to get people to quit caffeine.
Exactly. Exactly.
So it's basically like, we're not taught how to support patients. And there's a little bit of like, the kind of party line on the street is like, well, maybe do a little taper, maybe spend a couple weeks at 50% and then go off. Or like, sometimes there's a thing of like, take it every other day. Don't do that. And then really problematic is that there's a real denying and invalidation of people's struggles when they are in withdrawal. And you'll see someone say, well, SSRI withdrawal is not a thing. It's not actually, like, this is in your head, or you're just being anxious, or you're being annoying. And so patients get met with like a lot of being very dismissed and resistance, and no one's sort of stepping in to support them on the process.
Can I interrupt you for 1 second there? This is where it's quite scary that the medical profession, specifically psychiatry, is not keeping up to date with the latest research, because if they did, they would even see that WHO has issued a statement saying that it's absolutely confirmed that they've changed. The NIC guidelines have changed as well, NICE guidelines, that there are side effects of coming off withdrawal, effects of coming off antidepressants. So, it's a matter of doctors also keeping up to date with what is happening. Sorry, I just wanted to insert that.
Yeah, so this is so important. And as we know, like, these things always, there's such a lag in terms of how they're adopted down the many
downstream
rungs, where you find somebody in their like dusty private practice, and are they validating a patient's experience? Are they staying current? And to me, what ends up happening a lot of times is someone goes off their psychiatric medication, and then what their psychiatrist or their primary care doctor, whoever's prescribing it, says to them when they get symptomatic is, this is relapse. And so this is an indication to go back on the medication. This shows us, wow, you really were depressed. You really still are depressed. You really needed this medication. It was really helping you. That is quite a distortion. And I don't mean to say there's no such thing as relapse of depression. There truly is. But there's a trump card here. You cannot diagnose relapse when you're in the context of acute withdrawal. That is going to eclipse any potential for relapse because you are in a much more sort of like prominent state when you're in acute withdrawal. And so when patients are getting off of psychiatric medications, to me, I just want them to realize they are in withdrawal. They might feel very symptomatic. People feel anxious, irritable, they have insomnia, they have crying spells, they don't feel like themselves. I hate to say it, but very frequently people have suicidal thoughts.
Yes.
I think it's just so important for people to recognize this is not me, this is not relapse, this is not I'm broken and it's hopeless. This is withdrawal from a mood altering, a mind altering medication. And the more we can sort of, once we understand that, we can work with that. Then we can mitigate the withdrawal experience. It's usually in doing a dramatically more gradual taper than what doctors typically recommend. It's not a 2-week, 50% reduction. It's sometimes a 6-month or a year-long process to go gradually, which I also don't want to make people feel hopeless with that, because it's not like, oh God, this is going to be a year before I'm off meds. You're effectively off meds at some point, along that process.
Yeah.
And those last several months is really just helping your brain kind of rebuild receptors, restructure synapses. It's just keeping you out of withdrawal. It's not making you feel particularly medicated.
No, that's such a good way of saying it because it makes it a little bit more accessible. It doesn't make it so scary. It does take time. But whereas if they cut, as you say, the 50% or take half or every alternate day, that's too much of a shock for the system. So I know there's things like tapering strips. And so can you talk now about, you handled that really well, by the way. That was excellent answer. Because I know it's a very touchy subject. And my encouragement, if I just may wrap up around your answer there, is to encourage people to get informed, get knowledge, read up, find out. They are great. Like Robert Whitaker's book explains a lot of the truth about those studies and it's in accessible language. So you don't have to read complex studies to work out, is there a scientific bias in the study, which is very complicated to see if you don't know what you're looking for. But there are great books, and Mad in America has lots of blogs and things for people to be able to go and understand this. And you have information on your site. I mean, there's quite a few places where people can. So I really encourage people to get informed and make your decision based on facts, not opinion, not on feelings, but on facts. With withdrawal, how do people do that? And obviously it's under medical care. You'll guide people through that. But things like tapering strips, and what does it mean if you shouldn't take, cut down by half or skip a day, why, etc., etc. If you could give us some steps and guidelines.
So the way I think about it, I'm just going to use an analogy and then give the sort of the steps. I think about it very similar to in cardiology. If someone has blockages, like sort of stenotic blockages or plaque building up in the walls of their coronary arteries, that's what's building slowly towards having a myocardial infarction or a heart attack. And if that's developing gradually, so if that develops precipitously, if you just have a clot that goes to a coronary artery and occludes it, that's a heart attack. If they are developing gradually, if that plaque is developing gradually, your body actually has a chance to build what I think is called collaborative circulation. So it's almost like your body starts to build new blood vessels that go around the plaque. So, and it basically your body knows, like, this is risky.
Brilliant. Yeah.
Let's have a, plan B. I think it's very similar with medication discontinuation, is that you want to go gradually so that your brain starts building almost the equivalent of collaborative circulation. It's not blood vessels in the brain, but there's a lot that happens
networks.
In terms of, it's downregulation and upregulation of receptors, building neurotransmitters. And that just takes time and raw materials. You need good nutrition, you need rest, you need all of this time for your body to do that kind of housekeeping work. And so the more gradually you go, I find the less symptomatic the taper can be. So what I'll usually do if someone's on a straightforward taper, like they're on 100 milligrams of Zoloft, and this isn't exactly medical advice because this is truly something to be working closely with a practitioner who supports this, because it's a unique and different and sometimes very challenging journey for everybody.
Yes.
But I usually go down by about 10% of the original dose per month for the first several months. So if they were on 100 milligrams of Zoloft, we would go down to 90 and then to 80 and 70 and 60 and 50, working with a compounding pharmacy. So someplace that will actually build them
Build it for
a
them.
capsule that's exactly 80 milligrams of Zoloft, which is not something commercially available. We keep it more affordable by every time we get to a commercially available dose, like you get to 50 milligrams of Zoloft, you say, compounding pharmacy, we'll see you in a couple months. You go over to your local pharmacy and you get the commercially available dose. It's less expensive. And then once you get to the end of the taper, 10% of the original dose, 10 milligrams, becomes too big of a jump. So then it's more like you play around with it, nothing set in stone, but you basically go as fast or as slowly as the body seems to be indicating is the right speed. And, you're balancing like you want to get to the end of this taper with the fact that you want to go gradually and gently. And people usually really know for themselves by that point, like what's the right pace. And we usually make an adjustment about once per month. And I support the taper. And this is the part that sometimes
I was going to ask you, so how do you support it? Because I know you're big on that.
Yeah, so it's a very robust diet and lifestyle approach to giving your body all the conditions it needs to successfully rebuild and emerge from this like very sustainably well. So it's something that resembles like a Whole30 diet or a real food or paleo diet. There's lots and lots of individual variability around that, but more or less real food, avoiding fake food, lots like really prioritizing sleep, prioritizing movement, prioritizing meditation. We throw around the recommendation to meditate, like, it falls on dead ears.
Yeah, I know. It's because everyone's saying it. Yeah.
But when you're actually pulling a medication, it's in a very cut and dry way. Like when you're pulling a medication off, you're kind of pulling out the rug from underneath you.
Yeah.
And it puts your nervous system in a stress response. And then what you really want to do is combat that by very targeted action to put your nervous system into a relaxation response. So breath work or meditation or yoga nidra or whatever works for you, something that puts you in that feeling at the end of Shavasana, that relaxation response. It just helps balance your nervous system so that you can be at a comfortable baseline. And then I will have people do certain supplements and certain detoxification supports, basically just to kind of like, it's a leg up to make the process go a little more smoothly.
That's excellent. So, and then you bring in the exercise as well. So it's not just one thing. You're not just taking them off a drug. You're addressing the whole lot, and at the same time, you're also dealing with the emotional stuff. You're helping them to process that in the first place. So there's a holistic approach, and that is very unusual in this day and age for psychiatrists to be doing, because most of it's just diagnose, symptom, medication. You taking the time to spend, this is a lot of time you're spending with the patient in a withdrawal process, in that whole lifestyle change in terms of diet, exercise, the yoga, the meditation, the whatever you also do acupuncture.
Yeah.
This is amazing. I mean, and then Chinese medicine. So you've brought in everything and you offer that whole combination to your patient.
Yeah. And the idea of like time, I mean, time is the commodity that's been squeezed out of the medical interaction now, like now that we basically are down to like 15 minutes or 8 minutes with a patient, and sort of the opposite of how you get good results in this care. Yeah. So, I mean, for me, I spend 2 hours in my initial consultation with a patient, but that gets very expensive and inaccessible. So I also now just do online groups and make it donation based and just scale and make this available broadly. I think of it very much with an analogy of childbirth as how do you hold space for someone getting off of a medication? And there's sort of that obstetric, and I don't mean to sort of like just, it's broad strokes about obstetrics, but a kind of a reactive stance to something is challenging in labor and it's very reactive. You need an epidural. We need to go to C-section. It's very like, oh no, let's react and cut and do some very young or active intervention. Yeah. And the midwifery approach is much more like you're knitting in the corner and every once in a while you're like, you got this, mama. Or you're like massaging your back. And it's kind of like not so fear-based or so reactive. It's basically like, this is a journey that you're on. This is your sacred journey. I am here to tell you, to reflect back to you, you can do this. It's difficult, but you can do this. And it's basically much more of a supportive role. And to me, it's very important that I take a stance where if someone is freaking out in their taper, I'm not freaking out. I don't jump to a reactive or fear-based place with that. I've luckily enough have done this enough times with patients that I'm not afraid, that I see how strong people are, how, they can come back to purpose and intention and get through challenges. But I think that when you come to your psychiatrist and you say, I'm getting off these meds and I'm having dark thoughts, a lot of psychiatrists really jump to a kind of medical, legal, protective stance. And they say, you got to go to the hospital. And to be honest, it's sort of like, spirals.
Yeah, it spirals out of control.
And then somebody says, oh God, I'm even sicker than I realized. Like, I really just needed to talk about these dark thoughts that are often sort of ego dystonic. They don't feel like this is really, there's not intent. There's not like, this is what I want. It's more like it's scary and uncomfortable to have these thoughts come into my mind. I want to talk about that with somebody who understands, who listens. And so often that's what people need. It's like, we don't need a hospitalization. We need a 1-hour conversation. We need to get you back to seeing that there is reason for hope, to recognizing that these thoughts are external, that they're the withdrawal, that they're not you. This isn't what you want. And I think that that's the work. And it can be very touchy, but it's like, this is, there's a silent epidemic right now. There's a lot of people struggling with this at home, alone, ashamed, thinking it's just me, thinking it doesn't apply to other people. And I'm hopeful that we'll increasingly have a public conversation about the journey of getting off of psych meds, and that is, in fact, very universally difficult.
Gosh, what you've said is just so powerful and so important. We need respite homes like they have in certain periods of history, where they've had places that are beautiful, where people can go and just immerse themselves for a time without being forcefully, where the police are the first responders and the person is literally treated like a criminal and removed from their loved ones and taken away, and the fear around that, and locked up and forced medication and shock. There is this terrible, scary, and then that follows you the rest of your life. It's just terrible. We need that place where you're feeling broken. Just what you've described, everything. If we can get it one-on-one, if we can change our medical system to be able to supply this kind of intervention, and to get communities more involved, and then to have homes. Some people just need to take some time out of life and just go and to a place where it's beautiful and safe, and they can paint and they can talk and they can do what you've just described. That's part of what I'm trying to do with the work that I'm doing. And you and I need to talk about this more, because we've got to, I know it's Robert's dream, it's been Soteria, Robert Whitaker, Soteria House. There's been a few projects around that have been so successful, and the people have really gone through the description that you've described now in that kind of setting, and it's worked. But they've been shut down by the pharmaceutical companies because there's no money in them, because they're not taking drugs. They get them off drugs and they become fit back into society. So, it becomes up to people like ourselves to educate people and to get the initiatives going where we can, from a grassroots level, rebuild the respite home concept. And I know there's a few, like Dr. Peter Kinderman in the UK is pushing for this. And, there's a lot of people that are now, but there's a lot of talk. We need to actually have action put into place. So people like yourself that are already offering, like you said, group training, that you're doing group sessions because of the affordability. I mean, thank you. That's just absolutely amazing. I've created an app. I mean, we're all doing what we can, and the more we collaborate, the more we can actually do for people. And you also mentioned just about I just wanted to emphasize for my viewers, I talk a lot about neuroplasticity and what you described with the withdrawal process so incredibly beautifully, by the way. Thank you so much. The way you described the whole concept and how to do it. It's neuroplasticity. Your brain changes whatever you put in. So epigenetically, whatever you put in your mouth, eat, think, it changes your brain. So obviously it takes time for your brain to change back. And what's so interesting, which I've always told people when it comes to withdrawal and change, is it's more difficult to withdraw from the modern American diet, which I know you know, than it is from cocaine. And if you look at the list of addictions, psychotropics are number 4. So if you can get off the sodas and the modern American diet, you can get off psychotropics, because it's like modern American diet's number 1 and number 4 is your psychotropic. Cocaine is number 7. So it's just interesting to give people a perspective that this can be done. But we need more people like yourself. We need you educating the other psychiatrists and doctors on doing this. So there's my next question. I say all this to say that that's the changes that we are experiencing with the drugs is neuroplastic. The changes when you're coming off is neuroplastic, and that's why it takes time. It's the change of the brain. So to pivot now to the doctor question, are you training other physicians? Are other psychiatrists? Are the medical world? Are they listening to you? I know I'm training a lot. Are they listening to you? Are they hearing you? And are they changing? And is there a desire?
They are now. Yeah. So I think that for the longest time, like certainly in residency, when I was giving like grand rounds presentations on this, like nobody was receptive to it at that time. It was like, that's nice. That's nice. But I also was younger and hadn't, there wasn't proof of concept in my practice. It wasn't established. So I get it. Then I worked for a long time in a large primary care group, and I sort of went up at the podium and gave a lot of talks on these ideas. And like the most outlier open-minded among them were sort of receptive to it. But overall, it was like, this is too weird. I've now gotten to the point where some people come forward and they say, Ellen, it's really weird, but like that stuff you were saying 10 years ago, now it's coming true.
Oh gosh,
It's like,
coming true. It's been true.
so it's like now that the New York Times has caught up,
Yeah.
like now it's true. So,
Yeah.
but I
The
have
New York
found,
Times needed to confirm the truth of it. Gosh.
so I have found that, and I understand they have a responsibility
Yeah.
to be sort of like airtight in what they put forth. So that just means that they're 10 years late to the game.
Yes, which is always the case, 10 to 20 years before things are really applied from a scientific perspective into practice.
But it probably means they're also not promoting some things that are a little bit not valid. So good for them. But I think that in terms of training practitioners, so now that I do these groups pretty regularly, like every month I have a new online group, I'm seeing that increasingly, and I haven't like put it out as this is a practitioner training. I think at some point I will do one that's specifically for that. But it's just been like now 50% of my group participants are practitioners who want to learn this approach. So it's so exciting. And you see in this group, it's like extra magical because this is the community element and people are supporting each other and we're all learning, and you see you're not alone in being a seeker and sort of wanting to expand your understanding of what is mental health about. But you see, like, it gives all of us more hope to see this tidal wave of practitioners who are saying, I'm not satisfied with the model I was taught, and I suspect there's a better way. And so I am seeing a tidal wave now, and it gives me hope. Everything about 2020 is like, whoa, we are in
wake up call.
We're in the moment.
We're in the moment. We have such great opportunity to change. It's amazing.
There's reason for hope. Yeah,
there's reason for hope, and I'm so glad that physicians are listening to you. I find when I do because I also do a lot of seminars and conferences and things, and we have so many doctors now that are learning and training and changing their mind and being approached on all different levels. So I've seen a definite shift in the last probably 5 years, but especially the last 3 years. There's been a definite shift to this is not working. We have to have another. And especially your primary care physician, who very often, as we know, the first port of call that a person, I'm feeling depressed, and generally it's just a prescription is given because there's no training. I mean, you've been through medical training. You wouldn't get trained, even as a psychiatrist. How much mind training did you get? If you think of it, isn't that crazy?
None. Yeah. Like
exactly.
Almost none. Like and CBT, but apart that, no.
And even CBT is formulaic. That's like when I talk about CBT, the 5-step protocol that I've developed, it's one of the things you could do in the first step, only when you've done the actual human stuff, the psychospiritual stuff, all the other stuff, addressed all the other elements. But doctors are definitely becoming more aware. But around doctors, one physician a day is committing suicide. They're under so much stress and physical burnout and mental burnout. And we know the statistics, the medical, not just doctors, the medical profession in general. But I've seen from my discussions with doctors, and this is where I want to go with the question, there's this thing that, I can't admit that I am battling with emotional issues myself, because then I'm not going to be seen as a valid physician, or I've got to have it all together. You opened this discussion by saying you battle. Now, you are highly qualified, not just in one degree. You have multiple degrees, English major, which I think opened your mind to a lot of stuff, being an English major, medicine, psychiatry. I mean, it's Chinese medicine, acupuncture, functional medicine. You've really, and your first statement to me was, to all of us, was you battling. And that's what we've got to, because and I've been approached by physicians, it's like they don't know how to manage their own mental health, let alone help their patients with mental health. And so there's this disconnect, but then they've got to act like, I've got the white jacket on, I'm superior, I know everything God complex, but I can't live into the God complex. That's a major issue. And if we give our physicians permission to feel the emotions, we can then relate. That's makes you so relatable. What do you think about that? What is your...
In a way, like, it's crazy that we think that it would be somehow something that detracts. Like, to me, it's the most important credential, right? Is like, I really struggle to treat patients of anything that I feel like I haven't experienced in some degree myself. Because it's like, what do I really have uniquely to offer here? When I've been in it, like when I've been inside of a condition, like I feel like I know my way around. I know the pain points. I know how to speak in a language that people say, you get me, like you understand this. So I think like it's, rather than something that should be shameful or somehow invalidates our capacity to help it, I think it really is the asset. It's the credential. And I look at doctors and I have a lot of strong thoughts about this. We could go down a fairly radical tributary about the fact that I think doctors are also very medicated. And I do find this is controversial, this is delicate, but I worry that the more medicated we are as a culture, there's something that psych meds seem to do for some people, which is that in the on-ramping and the off-ramping, like when you're starting a med and when you're getting off of a med, which is might be you're tapering or you missed a dose or you changed your dose for whatever reason, you're switching meds. In those transition phases, I see a significant uptick in suicidal thoughts alongside occasionally this very kind of lethal combination of being a little dissociated, things feeling a little surreal, and things feeling a little bit numb and a little impulsive. That combination is incredibly dangerous. So I worry sometimes that the fact that, we're more medicated makes us more at risk of more suicide. And I look at doctors, and doctors can prescribe for themselves, can prescribe for their friends, like are just plugged in, or sort of like, psychiatrists. I just feel like they're on so many psych meds, because they're just like, that's their world. I think like dermatologists get a lot of Botox and psych meds are on a lot of Klonopin, and it's like you're surrounded by it. And I think that it makes doctors very fragile. And I also know, and I identify with this firsthand, is that you go into medicine, you don't go into medicine for the wrong reasons. Too many hoops.
Too much of a commitment. Yeah.
Too much of a commitment. It's not a pretty journey. It's not an easy journey. There's nothing about it that's like, this is an easy ticket for an awesome life. It's never like that. You go in for the right reasons. And then over the course of the 9 or 10 years that you're in training, you're sort of systematically, you shift to it, you arrive at a slightly different place. Some people, and like I know my colleagues, they're smart, hardworking, their intentions are good.
Yes.
Some people find a pocket to practice in a way that's their passion. They are practicing in alignment with their beliefs, and they're out there like Mother Teresa-ing and just like doing God's work. And thank goodness for those folks. And then a lot of people find themselves making a series of decisions because they're in a lot of debt, or because they're burned out and they just need a good lifestyle, or whatever it is. People make a lot of decisions where they end up practicing in a way that's not perfectly in alignment with their truth, with their values. And I think that's a very toxic way of living our lives. And I think about that, like there were little pockets of my career where I was like entertaining those kinds of jobs. And I sort of did the imaginary exercise of picturing myself showing up, like waking up in the morning and going to work and doing that work. And it would have crushed my soul. And I think that, there is a way of, to me, that puts people at risk of suicide, is like feeling locked in and that there's no path out. And you just feel like, what am I doing to the world? Am I a force for good or not?
Wow, you said that so well. So this is something that has to be addressed. I think we should have another discussion just completely around that. And we didn't even touch on the sleep. And I mean, this is like you and I could, like in the beginning, we said we could talk all day. I want to make one comment about the withdrawal and the Lexapro and the doctors. In my most recent clinical trial, one of our subjects who's in experimental was on Lexapro and had tried nothing was working, and depression like really severe and just everything, like not sleeping, the whole everything. And one of her things is, first of all, we put on the mind management, and she went through the cycle of 63 days, which is the whole neuroplasticity research I've done. And it honestly, the QEEG, the behavioral, the physiology, the narrative, everything dramatic. She got it under control. She was managing. The depression lifted to a point where she was managing, which is amazing. And it was sustained at 63, sustained at 6 months. So it's really a radical change. The point I want to make in relation to that is mind management works when you get, which is what you've been saying. So there's evidence of everything you're saying. I'm seeing this in my clinical trials because it's a very holistic approach too. But also the interesting, because I know you talk about Lexapro, I've heard you speak about that in terms of withdrawal. She is on Lexapro, was coming off it. One of the things that we know with Lexapro and any antidepressant is your awareness of the ability to have insight is not very good. And that was with her initial intake. She could describe in her narrative how she was, but when she filled in the traditional, because we had traditional psychiatric protocols and scales that she'd seen before, it was almost like she wasn't depressed. And then her insight, the scale that I developed, it really looks at insight and what's really going on in your unconscious. There we could see how depressed she actually was. So she was living in cognitive dissonance, and a lot of that had actually affected. And as she got more mind management, that became her awareness increased, so her empowerment increased. So I'm relating this back to doctors. I mean, there's a whole conversation around this, but relating back to doctors who are on things like Lexapro, awareness, insight is lacking. We saw energy changes in the brain where your ability to actually integrate information from different areas of the brain, which is not multitasking, it is actually a natural internal function, is not operating like it should. So this leads to compassion fatigue and physician burn. This is very real. So it's not helping, it's making it worse. And it also does something weird with the DNA, the telomeres. Initially it ups them and then it decreases them. So there's so much cellular health that's being affected too. And so this is something that needs to be addressed and education for the medical profession, not just the public. So that's just
Here's where my brain fires too when you say this. I so resonate with this. And I think that, I think about when we're on oral contraceptives and we're trying to choose our mate for life. And it's like, it actually impacts our ability. You're really trying to smell on almost a pheromonal level.
Yeah.
Who is compatible with us. It has to do with how different our immune systems are, and I think that when that's impacted, we might make different and perhaps worse choices about who we're compatible with because there's a barrier to that, our ability to sense in that way. And I think about it, I'll admit this is sort of shameful for me, but I don't know. It's nothing to be ashamed of. I want to sort of scratch that word, but it's like, this is something I don't admit publicly typically, is that the couple months before my wedding, I got Botox for the first and only time in my life. And
that's okay. It's your wedding. You're allowed to do these things.
but I was still a psychiatrist, and I noticed that I would sit across from a patient, and I realized so much of my insight and my capacity for empathy and really understanding what someone was going through came from mirror neurons. And mirror neurons,
of course,
they're in relationship to your facial muscles.
Your face.
You're mirroring. And I was almost missing some data because my face could not and wasn't mirroring. I was like sitting there like,
that's insane.
And it impacted my insight. And I think that so many of doctors, when we're actually able to be healers, not just technicians, not just providers, but healers, there's so much witchcraft happening under the surface.
Wow.
And we want all of our cylinders firing. We want all of our capacity for picking up and observing and sensing and listening and feeling. And I think that I don't mean to say, like, if you're on Lexapro that you're not feeling. Certainly I've had so many of my patients who couldn't get out of bed and then are on Lexapro and they're thriving in their life. So it's not all, there's just nothing 100% about this. But I have had patients who've gotten off of meds who have felt like I am now for the first time feeling like myself, feeling more deeply, feeling more in general. And I think that, for us to show up as healers, I do think it is helpful for us to be like really with a big antenna.
That is such a great example of that's brilliant. Thank you for sharing that, because it kind of wraps that up. And I'm glad you just, sometimes we just need, you mentioned one of your patients that I think didn't want to initially come off Lexapro, and then 4 years later, once they had worked through, or whenever it was, or 4 months or something, they did. And that's the thing, maybe because it is suppressing the emotions, but maybe they needed that hiatus. But then they've got to be prepared to go through the withdrawal, because it is going to change the brain and the body. So there's there's so much complexity and so much to see the person as an individual case study. Okay, we'll have to stop here. We'll never stop talking, but this is just the beginning. Thank you for your insight, your wisdom, your work, your contribution. It's just phenomenal. And I can't wait to talk to you again.
Caroline, thank you so much.